This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. A 70-year-old man with pseudoexfoliation, moderately dilating pupil, and an intumescent lens is posted for cataract surgery. The antechamber is shallow, the lens is swollen, and there is hardly any space in the peripheral antechamber. Couple of challenges which we encounter would be the pupil. We need to take care of the pupil to dilate it mechanically using a pupil expansion device. And second would be to deal with the intumescent lens. At the slit-lamp examination, there was no evidence of any phacoemulsification. So zonules look to be fine, but nevertheless, we need to be cautious because zonular weakness is to be anticipated in such a situation. The choice of pupil expansion devices I had to make, the two common ones which I use is the BHEX device and the Gupta expansion device. And now in this special situation, I would want to choose a BHEX device consciously simply because we don't have much space to manipulate. So I would prefer to have a very thin device, which the BHEX is. My concern is when I'm trying to manipulate the pupil expansion device, there's always a risk of rupturing the anticapsule because it is swollen and convex. And there's every likelihood that during the manipulation of a thicker pupil expansion device, the chances of damaging the anticapsule are high. And that's the reason why I have chosen the BHEX device in this case. I'm not going to attempt any stretching in this patient simply because even during stretching maneuver, there is a risk of touching the anticapsule and disrupting it. So I would like to do the stretching if at all required after the implantation of the expansion device. The two side ports are made, the capsule is stained. Now there is a small trick to stain the capsule which is hidden by the pupil in these non-dilating pupils. I'm using only few drops of trypan blue. As you can see, they're dropping down on the anticapsule. And some of them have percolated behind the pupil, that is under the iris. And this I can note because the iris has come forward and the air bubble size has shrunk. So at this time, if you put more pressure, there's every likelihood that the dye can extend beyond the zonules into the burger space. And we could have the blue fundal glow phenomenon. So to avoid that always, now before washing off the dye, what I'm doing is I'm decompressing the antechamber by pressing on the posterior lip of the side port incision. We can see that some of the dye which is behind the pupil has come out. And this is a good sign. If we use positive pressure to wash off the dye at this point, the pressure itself can push the dye across the zonules into the burger space. So always decompress the antechamber first, get all the dye which is gone behind the pupil in front of it, and then I'm going to irrigate with BSS. This is how we're going to prevent any possible fluid misdirection. In this case, it could be the dye. Now is the time to fill the chamber with OVD. A dispersive OVD is placed into the antechamber and the air is burped out. The main incision is being created. I prefer a triplanar limbal based incision. Initial posterior limbal groove is created by a 15 number blade, creates an intercorneal tunnel of about 2 mm in length, and then the final internal entry is done. So we have a 2.8 mm incision ready. Time to place the BHEX device. This is the orientation of the notches which I prefer to have, and it is placed in the pupil. At this point, it's important for me to remind myself that during the maneuvering these notches onto the pupillary margin, there is always a risk of the anticapsule getting ruptured, so I need to be mindful of that. Slowly but surely, the BHEX forceps is used to maneuver the notches onto the pupillary margin. The first two sets of notches are engaged. The hand is switched. The last pair of notches then gently engaged. So now we have a pupil dilatation of about 5 to 5.5 mm in size, and it should suffice for managing the nucleus. Time to perform the rhexis. The pupil, which is now expanded to about 5 to 5.5 mm, provides an excellent template for me to size and center my rhexis. So I'm going to use my forceps to perform the rhexis and ensure that the tearing is done along the margin of the pupil so that I have an adequately sized rhexis. And during rhexis, I was happy to know that the zonules are very healthy and there's no issues related to zonules. Time to emulsify the nucleus. As is customary in all mature cataracts, I usually avoid hydrodissection. The phaco probe is now being inserted into the eye. The superficial epinucleus in the cortex is being aspirated out. Plan is to do a direct chop, but before that I would like to create a small trench in the center of the nucleus so that I can get a good hold when I'm attempting my vertical chop. To do the chopping maneuver, I'm going to use the longitudinal energy. A short burst of phaco is given so that the tip goes in and buries into the substance of the nucleus. The vertical chop is placed directly in front of the tip. Chopper goes down vertically and then laterally, and we have the first crack. The nucleus is rotated and tip is buried, and again this chop is made. At this point I can note that a small leathery plate is still holding on to the apical region. So the posterior plate is still not totally separated in this fragment. The nucleus is rotated and the chopping is continued. So it's important to do the lateral separation maneuvers a couple of times more. Simply because in these denser cataracts it might be difficult to break the leathery plate in the first instance itself. The nucleus rotation is continued and further chopping maneuvers are done. Now once I feel that we have got sufficient smaller fragments, the first fragment is pulled out of the bag and then emulsified. Subsequently, the other two fragments are emulsified in a very controlled manner. The remaining heminucleus is rotated and brought into the angle of attack. Now in this heminucleus, all the quadrants are attached at the posterior plate in the apical region. So the fragments are not free. In such a situation, I resort to the flip up the base and then phaco it. This is the strategy I prefer to use. Let me freeze the frame here. You can see this is the bridge which is holding all these three pieces together. Now with the second instrument, the nuclear fragments are maneuvered so that the bridge comes in more anteriorly, and I have got good access to phaco this bridge which is holding on to these three fragments. I would be using the sculpt mode with very low flow rate and vacuum so that there is no risk of causing sudden surge or hitting the posterior capsule. In a very controlled manner, the bridge is destroyed by emulsifying it, and now all the three fragments are free. At this point, I note that there is a small geographical patch I see on the corneal endothelium. Well, it was confusing whether it's on the epithelium or the endothelium. I believe that it's on the endothelium. This is probably a small descent membrane which has been stripped off during the manipulation. I went back and checked the video a couple of times, but I couldn't really exactly figure out at what stage it happened. Nevertheless, this is giving me some concern now. Again, under the cover of viscoelastic, all the fragments are emulsified in a very controlled manner. Now this small defect is seen very well against the red glow. So this is sort of a cause for concern for me now. The remaining cortex is aspirated. Chamber is filled with OVD and the planned intraocular lens is maneuvered into the bag. Time to remove the BHEX device. The notches are disengaged using the forceps again. Once all the notches are disengaged, just go in through the main incision, hold the device and then pull it out. Because it's a uniplanar structure, it's so easy to remove it. Time to remove the OVD both in front and behind the lens. Time to close. The side port and the main incisions are hydrated. Intracameral antibiotics are placed, and that's it, the case is done. And this is the first post-op day. We have a central corneal edema, which is owing to the fact of the descemetorrhexis, should I say, was in this area which had happened. And fortunately for me, by the third day, the cornea is cleared off significantly, and it was a relief. So to summarize, this was a case wherein there was a constraint of space and there's a shallow entry chamber, and a swollen lens and a non-dilating pupil. So in such situations, I would prefer to use a pupil expansion device which is very thin and which is not very rigid, and it's very less likely to damage the intraocular structures, especially the swollen anticapsule in such a situation. Of course, immaterial of what device we use, we need to be mindful and be very gentle when we're trying to engage these notches. And the second aspect was, well, I had a central endothelial defect. It was mimicking something like a desmotorexis, but thankfully in the first few days itself, it resolved and the edema also resolved. So that was it. Thank you for watching and hope you found this helpful.